Hi, everyone. I'd like to welcome everyone to the fourth part of our five-part webinar series. Again, this is James Pat. I'm the Chairman and CEO of Insight Health, and we're excited to be one of the sponsors of this event. As you know, the goal of this series is to provide a platform for the FQHCs to learn and discuss several key topics regarding this transition to value-based care. If any of you have missed any of the previous webinars, they have been recorded and they're available to everyone. If you haven't received a link already, feel free to contact us and we'll provide you a link where you can download the previous presentations as well as the recordings. Before we get started, I'd like to thank all of the sponsors. Again, Ohio Association of Community Health Centers, as well as Cardinal Health and United Healthcare in helping to promote and sponsor this webinar series. Okay, so again, this is the fourth part of our webinar series. We've got the last one, which will be next week, and then we also are going to announce a panel discussion at the end of this, which we're excited about as well. Today, we're very excited to have Dr. Ted Wimslow with OACHC speak on patient engagement. Again, I'm very excited to have Dr. Ted Wimslow be our speaker today. A little bit of introduction for Ted. Ted's a family physician with over 30 years of experience as a clinician. He's immediate past director of the Ohio Department of Health from 2011 to 2014, and he was appointed by Ohio Governor John Kasich. Prior to his appointment at the Ohio Department of Health, Dr. Wimslow served as the Director of Family Medicine in Dayton, the PCMH initiative. As the ODH Director, Dr. Wimslow established the Ohio Patient-Centered Primary Care Collaborative, convening stakeholders from across Ohio to effect healthcare delivery reform. Today, Dr. Wimslow serves as the Chief Medical Officer of OACHC, with 44 FQHC members serving 575,000 patients in 232 sites across the state, 117 of which are PCMH recognized. He is also Senior Advisor to Better Health Partnership, an alliance for improved healthcare in Northeast Ohio, with 84 primary care practices across 7 counties. Dr. Wimslow sits on the boards of Ohio Academy of Family Physicians and Better Health Partnership and serves as a volunteer family physician at the Physicians Free Clinic at Columbus Public Health. He graduated from the Ohio State University College of Medicine, is board certified in family medicine, and a fellow in the American Academy of Family Physicians. He served as a program director of the Miami Valley Hospital Family Medicine Residency Program for over 20 years, and is an adjunct professor of family medicine at the Ohio State University College of Medicine. Dr. Wimslow has received a number of recognition awards, some of which include the Ohio State Medical Association's Physician Advocate of the Year Award in 2014, and most recently the Patient-Centered Primary Care Collaborative's first Primary Care Community Leadership Award in November 2014. With years of experience in both primary care and public health, he continues his efforts to improve population health in Ohio and the nation. So again, Dr. Wimslow, thank you so much for taking the time to talk about this very important topic. I'm going to go ahead and hand the controls over to you.
While we're getting that all together, thanks everyone for participating in this portion of the webinar series. Today we're going to really focus on patient engagement. It's escalated in importance during the last several years as patient-centered medical home has brought its, importance in the outcome side of the equation to the fore, understanding how critically important that the patient be engaged in their care in all aspects of the care if we're hoping to achieve the outcomes that we've all set and the goals that we've all set for our interaction with patients. One of the questions is, what are patients looking for? It's supposed to be about engaging the patient, but how can we be more effective in engaging with our patients? Well, we have to know what they want. And these days they're looking for better preventive care. People want to be able to not only live a long, fruitful life, but be high functioning at all stages along the way. They want close personal relationships with their doctors so they know you. They're not just another name on your schedule. but instead have a relationship that knows that you understand them in the context of their family and their family in the context of the community in which they live. And they're looking for, of course, enhanced services, and that includes access, enhanced access to care and convenience, and also communication, effective communication with their doctor. So access and communication have been highlighted over and over again as being the driving force behind patient decisions, and we're seeing that play out, I think, as we have new ways for patients to be connected with us. So the new direction in healthcare, where are we going? Well, some of you are old enough to remember Marcus Welby and how he would manage one patient a day and somehow be in the hospital, on the road, in the nursing home, in his office, and many other places each day. And we've kind of replaced that physical capability that he showed by using teams on the right-hand side who are dividing up the responsibilities of the total patient care, but patients still want that relationship that Marcus developed and maintained throughout what he demonstrated as being a primary care service delivery model from the old days, 40 years ago. So how do we give that personal touch but still maintain the comprehensive focus that we have to have today with more that's been developed in our patient care models, and how do we engage teams in the process? So we're trying to go right now from this fragmented model that we've struggled with during the last 20 years, and that is so much has happened that's available to patients. They've actually divided up their care in multiple sites with multiple clinicians providing health interventions in their life. The problem is those haven't been very well connected. So that separation has created some duplication, some concerns at times with safety, and certainly driven up the cost of care without necessarily improving the quality that's been achieved. So where our focus has been as a state and as a nation now is to better coordinate care by working with our patients as partners, but also by working with other healthcare providers, sharing information, making sure each one's aware of what the other one is doing, and by doing so, not only ensuring a safer experience for patients, but also a more cost-effective delivery of patient care. So the patient-centered medical home, many of you know I've been around the state of Ohio advocating for this, and people have responded. We have now over 600 PCMH sites around the state of Ohio that are recognized, accredited, or certified by the various agencies out there. And those 7 core principles, including having a personal clinician who knows you and knows about you and you know them, having a practice team that has one leader but has a team of people together providing jointly the care for the comprehensive needs of the patient that they're seeing. Having a whole person orientation means we're looking at the mind, body, spirit, we're looking at the biopsychosocial needs of the patient and not just what they walked in that day complaining about or not just their physical well-being as traditionally has happened in traditional primary care offices. Coordinating that care has been a challenge both within the health centers themselves and also the external connections that are needed, and that's where much of the electronic capability that's come to fore the last several years has really helped us to have a global picture of what's happening with the total health of patients. But that's not been easy, as you all know, and you've all suffered through all this IT transition that we've been involved with, and that's continuing to make it easier and easier for us to have that whole picture perspective of patients. Well, quality is still a major area of focus. There's no sense in doing this if we don't enhance the outcomes, and so what we're measuring with quality is going from process measures to more outcome measures, and of course safety has been enhanced by having this better coordination of information and information exchange that's been happening between providers. Well, enhanced access to patients has been critically important, and many of you have noticed, of course, that patients are looking for convenience. That's why they're going to CVS and going to Kroger's and, you know, going to urgent care and other episodic care settings, and we want to enhance the access in our own settings so patients will always approach us first for all their health care needs and their advice that they need to lead long, healthy lives. Well, if we don't change the way we pay for services, we'll not change any of the above-mentioned components. And so payment reform has been a large component of where we've been focused in Ohio the last several years, with the State Innovation Model Grant, and insurers have been working closely with all of us to see if we can't find a better way to pay for the outcomes we're trying to achieve. Well, what we're trying to do with this whole PCMH coordinated care model is enhance patient experience. It's one of the major goals that we'd like to achieve by this care coordination. And so coordination is the key word in this PCMH model to remember, but patient experience is one of the important targeted goals that we're trying to enhance. Well, clinician-directed teams are very familiar to people in federally qualified health centers. We've got a variety of different clinicians of various types that are trained in health professions that are working together to do what in the past we expected the physician to do pretty much on his or her own. That is to work in teams looking at the various components of the needs of patients to join that information together into a collective report that has all of the important health information housed in the medical home. So the word home in patient-centered medical home refers to where the information resides in total that is collected from the various health providers in the various settings in which they see the patient, but it's collected all into a one home site where now the single entity, the patient-centered medical home, can serve as the orchestra leader for all the various components that are involved in affecting patient care. And we've got many, if not all of these, in our federally qualified health centers where patients oftentimes have a one-stop shop experience and they can get all of their needs cared for under one roof. Whole person care means we have to understand many things about the patient that in the past perhaps weren't the focus of clinicians, and that is, what does the patient believe? How do they feel about immunizations? What does their family feel about the family structure and what it should be? What are the patient's preferences? Where do they want to receive care? What type of concerns do they have that they want to address first? How does the patient's social environment affect their care? And you know, you all are very familiar with social determinants of health and how critically important knowing about those and considering those are in determining the best plan of care for the patient. So that would be what's their education level? Are they employed? What's the nature of their relationships that they have in their families and in the community? How safe is their community in which they live? Can they afford their medications that we're prescribing? And it goes on and on from there. Those components become actually a more important impactor of healthcare than some of what we do in our own clinical setting. And so we're paying more and more attention to those environmental factors and other factors that ultimately have a major impact on total health of the patients we serve. Well, how does the patient want to communicate? You know, we can set up all these electronic communication systems, but if people aren't connected that way, that's maybe not for us effective. Telephonic communication, texting today, and for many of you, the need to actually be able to translate from other dialects and cultures is critically important in your centers. And where's the patient starting from? That is, how much do they know about health and health care? How interested are they in their total health and moving that into a positive direction? And what does motivate them? What for them serves as the reason that they make the changes that they need to make in order to have that life balance that we're trying to provide for our patients? Well, we have to have enhanced access to care to have that capability of patients contacting us first when they have a health question or a health need and not go to other options out there that are part of the fragmented system that we still belong to. So same-day visits are part of the patient-centered medical home core principles. Less wait time for routine visits is expected by patients today. 24/7 on-call availability so that if a patient has a question, it's 2 in the morning on Saturday and they wonder, should I go to the emergency room? Can I wait till the morning? They can call and talk to a clinician who can advise them on that. Patient portals have enhanced the connectivity of patients to their information, their ability to schedule their own appointments, to get lab information and other feedback, is really engage them in a way that allows us to now have them serve as better partners in their own care. Some of our centers are providing e-visits, doing e-scheduling, and texting securely with patients has been implemented in a number of centers because, again, that's what the patients want. That's what they're more comfortable with. And we have a much more mobile society we live in, so we want to make ourselves available by other methods. Having ancillary services in our centers enhances the chance that patients will follow through with our referrals. So I know many of our centers do have dental care. We've got pharmacies in many of our centers, social workers. Now we have optometrists and podiatrists and other services in many of our centers so that the patients have a convenient way of seeing multiple caregivers, especially when transportation is an issue. That really enhances the chance that we'll get the comprehensive needs of patients better met. And then in some of our centers, we're starting group medical visits. Originally, that started around chronic diseases like diabetes, hypertension management, heart failure management, and most recently, people have seen that being used in the centering pregnancy model with a number of our centers, bringing in groups of pregnant women who are due at around the same time to bond and assist each other and support each other as they transition through that prenatal period. Well, quality, of course, is bottom line what we're all trying to enhance if we can, and we have our routine quality parameters that we measure, like how we're doing with our diabetes, heart failure, coronary artery disease, or high blood pressure management. But today we're focused more and more on prevention, screening efforts, and also looking at our proactive approach to enhance total health of patients by focusing on diet to get at our obesity epidemic we have as a state and as a nation, focusing on activity, which has an impact on many of the above diseases that we mentioned that we follow, and importantly, looking at emotional well-being because of its huge impact it has on physical health of the patients that we're trying to serve. So the Institute of Medicine got involved in this a few years ago, and when they looked at patient-centered care, they said it's providing care that's respectful of and responsive to individual patient preferences. So instead of looking at the convenience of our centers and what we need to operate as efficiently internally as we would like to, that is starting at a convenient time, ending at a convenient time, and perhaps at the end of the day, not worrying so much about what's happening with our patients when they're not physically in front of us. Now our focus is, what does the patient need? What does the patient want? How does the patient define a crisis or an urgent need, and not how we define it? And looking at it from the perspective of the patient so that we can better address and meet the needs that they have in their life, and that they look to us more and more often as being the source of information about any of their health needs that they have. Well, several years ago, the Lewis W. Sullivan Institute for Healthcare Innovation, they put together a patient experience council and said we might want to define some of our guiding principles for patient experience-centered healthcare, and we should be focused on the experience patient has. That is more than just their satisfaction. It also includes the quality of the care that's delivered to them in the health setting. So when you combine patient satisfaction with patient quality care delivery, that becomes the total patient experience that we're supposed to be focused on. And so they say number one focus should be the needs, values, preferences, and limitations of the patient. And in FQHCs, you're used to dealing with that every day because we really have to consider that if we're going to be effective in achieving our goals for the patients and the outcomes that we're trying to achieve. But that's got to be premised on shared decision-making. So that means engaging the patient as a partner and having them participate in developing the plan of care that they're going to own and they're going to be following together with us. So we have to recognize and value the role of the patient's chosen advocate also, because as you know, many times the patients get a lot of their direction on healthcare decisions from their family medical expert. Everyone seems to have one of those, and that's either the grandmother, it's the cousin, or it's the aunt, or it's the mother in the family, or someone serves as the health expert. And we have to recognize when we see patients that they're going to be touching base with whoever their family expert is, their advocate, when we give advice and we give direction, to double check and make sure that it makes sense. Inviting those advocates into the patient care setting when we do visits has been an effective mechanism of making sure that you're talking directly with whoever in the family is seen as being the one that they're going to run your direction and advice to them past in order to determine what their real course of action will be. Well, we have to have connected care both relationally, that is, we have to know the patient, they have to know us, we have to trust they will do certain things, and they have to trust us in what we'll do in a solid relationship. But we also have to know technologically how they prefer to be connected. Is it electronically? Is it telephonically? Is it by mail? Is it through others? And so finding those communication modes and using them effectively with patients will enhance the chance that they will use us appropriately when they need direction. And then we have to have smart care that's going to evolve over time. So the half-life of medical information is about 10 years, and that means every 10 years, half of what we know to be true today will be proven wrong. The problem today is we don't know which half is going to be wrong. So what we have to do is keep an open mind, continually learn, and be updating the patient's plan of care at all times. So an example of that would be what we're doing now with infant mortality in talking about safe sleep for babies. So 20 years ago when I was advising moms with newborns what to do with their babies, I told them to make sure they lay them on their stomach, right? So if they spit up, that they wouldn't choke on whatever regurgitates from their stomach. Well, now we know that was totally bad advice, and we now follow the ABCs. The baby should sleep alone, should sleep on its back, and should be in a crib so that it's got the best chance of not suffering crib death, sudden infant death syndrome during that first year of life. So we were giving bad information 10 and 20 years ago, and we're spending 10 or 20 years correcting that bad information because now it's widely scattered across the nation, and we've got to undo what we did for a number of years. Well, that's going to be true about many things we do with our patients that we'll need to update them on and educate them about in order to have them be assisted in making good decisions about their health, both when they're in your office with you and when they're outside of your office. Well, care teams have become critically important now in our centers. None of us work alone, none of the physicians, none of the APNs, none of the PAs work alone, but instead we work in teams. But with the patient, we have to make sure we are very clear on what our roles are. And so we have to know that with the patient, we're going to communicate a similar message, whomever is interfacing with the patient, and that will reinforce each other's message when they're in our dental component, when they're in the medical component, when the optometrist sees them, when others see them, that we're all on the same page following the same plan of care. But we have to remember the patient is a critical member of that team also, and whether it's the patient or that family caregiver who's the medical expert or the power of attorney that we're working with, we want to be sure we're being clear, that they understand it and retain that information. Typically we'll give a plan of care to the patient or their family when they leave our office, and that they can share that with others when they go home so that we all stay on the same page, including with consultants that see the patient outside of our practice. We also have to make sure that the patient not only understands their role, but they communicate it wherever they go, and that they know that they are the ones who own their plan of care. So it doesn't help them much if I'm the one in my office, in my chart, that has my detailed plans for them, and they're not only well aware of it, but they share it with others at home and others that they see in the healthcare arena. And that could be the chiropractor that they see, it could be the massage therapist they see, it could be the pharmacist they go to if they go outside our centers, but they need to be able to be cognizant and aware very much of what's in their plan of care, but also be willing and able to share that with others. And then we have to be sure that we update those roles and responsibilities from time to time, and that we connect new members at all times who become now engaged in the patient's health life, so that we as the center of their health coordination are constantly updating our information. And that means engage the patient in the process. So for me, with my patients connected on portals in practice, basically what I had them do before seeing me each visit was go into their record and validate the accuracy of the information there, or when they came in to visit me, let me know what had changed since the last time I saw them. Then when they came into my office, even though they had view-only capability with their patient portal, they could tell me what was different or changed, or what I didn't have correct in their past medical history, social history, family history, other things, and I would correct it during the visit. Well, that engaged the patient as a partner with me in making sure that my data and my information was verified and accurate and agreed with what they knew to be the way that their health really was going, and the past history that was impacting decisions that we would be making was correct. Well, now we want to make sure that we engage patients in patient-centered decision-making. So, you know, the old saying out there about change has been proven over and over again, and that is that, you know, change is really exhilarating when it's done with you, when you engage people in the change process, and it's very frightening when it's done to you. So in the past, and, you know, when we were more paternalistic in the way we approach patient care, patients oftentimes just said, tell me what to do and I'll do it, didn't question a lot, and if they did have questions, didn't feel comfortable bringing them up during the course of our discussions. Now we want to encourage patients not only to ask those clarifying questions, but also to be engaged in the decision-making process so that they then have a higher chance of owning those decisions and then taking action. Because all of our interventions with patients don't work very well if the patient doesn't follow through on recommendations that we together are able to put forward. So engaging them in decision-making is critically important, and that means that the patient ultimately owns their plan of care for their health, and that choices are framed by the clinician. Of course, we can give advice, we can give direction, we make the recommendations of how they can improve their health, but those have to be then shaped by the patient's goals, preferences, values, and circumstances, so it's customized to the patient individually, and then it gets implemented once the patient gives informed consent. That is, the patient ultimately owns that. So now you've become more of a consultant to the patient than the person who owns their plan of care. The patient now owns that, and with that, you enhance the chance that they'll actually follow through and achieve some of the changes that you together have decided would really positively impact their health. Well, a number of organizations have looked at this patient engagement activity and how it can work in practices and in communities, and one of those is Robert Wood Johnson Foundation, and they put together a number of different activities around the country, actually working with a number of their programs that were part of Aligning Forces for Quality to see how they could enhance patient engagement. And they define 4 levels of patient engagement, and there's probably more than this, but these were highlighted recently in an RWJ-sponsored webinar that they did. I thought I'd just bring these out to you to broaden how you look at patient engagement as not just what happens in your office in the examination rooms. One of those is community-hosted workshops, and that's where programs like the chronic disease self-management workshops are scheduled around the country following that Stanford model. And many of you may be familiar with that. And it's a chronic disease approach they take to anyone with chronic diseases. It doesn't matter what they have, but they help the patient to try to live a healthy life in spite of the fact that they have some type of a chronic condition. And they have trainers that go into communities and basically run 2.5-hour sessions for 6 weeks in communities where this exists. And many times this could be in churches, it can be other community settings where they help people with a variety of chronic diseases learn how they can optimally achieve health despite the fact that they're struggling with a chronic illness. Other community-hosted workshops focus on specific diseases and bring people in communities together around specific topics, and probably the area agencies on aging are best known for doing that in your community. But also on chronic pain, there are more and more workshops happening at the community level and on other chronic diseases like hypertension, diabetes, and other chronic illnesses. So watch for those in your communities and referring your patients to attend those type activities, and if you would, go with them to see what they're hearing, is in many communities an effective way to try to see if they can't get global understanding of health and health issues better in the community and help the population move up in their knowledge base about health and what they individually can do as part of their responsibility to improve their health. Then there's also, and you're probably more familiar with these different levels, these are patient self-management focus areas here where we try to educate and give people tools in our practice or in the community, but also try to move them towards a greater ability to do their own care decision-making. And that's that shared decision-making model, SDM, that you hear about, where the patient becomes engaged and becomes a partial owner and ultimately the total owner of their health plan of care. So in your office, you do this every day, both yourself individually in the examination room and also connecting patients in your office with dietitians, pharmacists, social workers, using your nursing staff, your oral health staff, and others to help make sure the patient has a good understanding of what they're facing as far as either a health challenge or a goal of optimizing their health by being as healthy as they can, and what can they do to make sure they have good outcomes in their health in a prevention type manner. Looking at developing that personal plan of care jointly by negotiating and discussing that with the patient using things like motivational interviewing techniques to get at what's the top priority for the patient, what are they committed to changing as far as their lifestyle choices they're making, and then following them through those changes so that you would help ensure that you go from step to step to step in their stepwise approach towards better health. You want to connect patients with their information, which largely will be housed in their charts by using those portals. I know many of your electronic records have them, but using them effectively becomes that next challenge, connecting patients and giving them access to their health information and having them use their portals for scheduling purposes. Also, so then they have more ownership of their health decisions becomes really important. But also with your electronic systems, being sure you're connecting patients to reliable information sources so that they're not surfing the web looking for whatever they can find that tells them what to do with their rheumatoid arthritis or with their lupus or with their other questions that they have. They will find answers to those questions. It's up to us to make sure that we are directing them towards reliable sources of information so that when we see them in our visits and we talk with them in between visits, we're all on the same page on what we expect they would know and the actions they would be taking. Well, group medical visits, as I mentioned, has become a little more popular, but I think some offices have, depending on the population you're serving, been more successful than others in bringing groups of patients together in your office and having them talk with each other, with it being facilitated by a health professional to, in the process, allow patients to provide support for each other and advice for each other on how best to get through some of the challenges that they're facing. Now, in lieu of that, or in addition to that, we have now the community health workers that are from the community who are ethnically and culturally connected with the population we serve, but their value becomes going into the community and connecting with patients where they live, patients where they work, patients out in the community where they're actually practicing the things that we're talking about in our office. So community health workers are taking off as a concept. The training of them has improved over time. In Ohio, like many states, we're still deciding what's the best way to put them to use in our practices that you and I can afford to do also, because reimbursement is still a bit of an issue on determining how best to pay for this additional healthcare worker that's being added to our workforce. So that's being developed as we speak, and I encourage you all to become more engaged in that. Some of you have worked in the hub model, so you're familiar with community health workers, especially in our prenatal care that we're trying to deliver that's so importantly impacted by the community in which the pregnant mother is living. Well, if you look at other levels of patient engagement, there's this patient partner model that's described, and basically that's having the patient partner with you in how your practice operates too. We talked earlier about them partnering and developing their own plan of care, but now how do we involve patients in things like improving the performance of your practice as far as achieving your quality goals that you set, or other PI projects that you have to streamline and make your practice more efficient, but not, in doing so, remove it from connectedness with the patient and what the patient's looking for in their experience. So engaging the patient in those decisions and in some of that committee work that you're doing can be very valuable to make sure that you're not changing without the patient being aware of it, engaged in it, and making sure that, you know, you're doing something that the patient will predictably respond to in a positive way. In other practices, they have patient or family advisory councils that meet on a regular basis and look at a broad range of topics that they can provide feedback on or input on things like satisfaction surveys, patient experiences, the CAPS survey results that you get. The patients can reflect on how to better correct some of the challenges that we are faced with as we do satisfaction surveys from patients and say, I don't know what those patients are thinking. Why would they think we could provide something like that in this office? They're asking too much. If they would just do what I tell them, everything would work out just fine. You know, you hear these things and you go, that's probably not going to get us to where we're trying to get with the population we're serving. So these advisory councils are seen as ways to see if we can't move our entire population forward in the experience that they receive in our centers. And then last but not least are patients as champions. And so what patients can do with you is give you feedback and help you improve your referral processes because, you know, much of healthcare expense and a lot of the quality of the outcomes is determined by who you refer to and how the patient fares once they've been referred out of your practice to another site. Well, we don't always get that feedback from patients, but they have a lot to say about who you send them to and how that goes and what the cost is that's incurred in those processes. And for us, with that feedback, could really help us in that patient-centered medical neighborhood development that we're really next moving into, which is, are we using effective consultants? Are we referring to providers that not only provide excellent quality in the outcomes they achieve, but also do it in a cost-effective manner as we're all trying to get at that total cost of care and the total quality of healthcare that's delivered to our patients. So that's looking a bit outside our practice, but that feedback from patients can help dramatically so you'll know who to send patients to and maybe who isn't in, you know, the best position to receive the patients that you refer. Patients can also help in standardizing your evaluation and treatment methods that you use for common conditions. So what you're doing in your practice as far as how you approach common illnesses, and is that effective? Is, from the patient's perspective, is it for them something that works as far as changing their behavior, being affordable, being something that produces the outcomes you're trying to achieve? That feedback from patients can really help in your office to define your practice and your care guidelines that you follow and the protocols that you follow in your practice. And we saw some of that when we talked about colorectal cancer screening and what you're using in practices. Well, feedback from patients was that a lot of times the options we give them, for instance, colonoscopy, aren't for them particularly effective as a choice. They can't afford it, or they don't want to go through that process, or they aren't good at follow-through and they need reminders or other methods to ensure that they follow through with some of the guidance we've given, and that maybe needs to be provided to them by someone who's culturally and ethnically connected to the patient. So from the patient feedback, many of our practices have changed the way that they're approaching that, giving more options to patients and having longer conversations about what they think about the choices they're being offered to try to get them to actually get something done of the many choices that are out there. And with that, we hope as a system, the federally qualified health centers in Ohio can move up from our 31% adherence to current guidelines, ultimately to 80% by 2018 is our goal. Well, we won't get there if we don't work with the patients, get their feedback, give them choices, and engage them in the ultimate shared decision about what they'll commit to. Patients can, for you, be a very valuable connector to community data on health. And they have connections to the schools, they have connections to public health, they've got connections to workplace, health that's going on and can bring back to you information on how all that data out there is impacted by the choices you're making in your practice. So if they know at work, for instance, that there's an obesity problem and basically their job and job site is starting a new program to try to help with obesity by changing the food in the vending machines, giving them walking breaks, encouraging people to bicycle to work instead of drive cars and other things, and they're having an impact with that, that's something important for you to know and share with other patients that are in workplaces that aren't already taking that type of effort. So you can have that community impact, but you have to know about it and know what's happening in health surrounding you in the community. So what's going on with recess? Are kids playing or not? Do they have activities where kids are actually encouraged to be physically active, or is that optional for them in the schools, and do you have feelings about that? Do you care about what's being served in the school lunch programs, and how is that impacting your kids' obesity epidemic that we're struggling with in our practices? So patients out in the community can give you that type of information and help you in your practice make better decisions. And then, of course, there's other health policies in the community that your patients can become engaged with. I know for many of my clinicians, they say, well, it's hard for me to do testimony. It's hard for me to help draft policies in communities. It's hard for me to go to the school board meetings. It's hard for me to participate in other community activities. But you have patients who can do that for you and with you or on your behalf who really do care about this, can be educated, and many times are more effective in the message that they give because they're giving a very personal story, and you know how powerful stories are of how health decisions in their life are impacting their outcomes, and how policies in the community and rules that exist in the community are impacting their personal health. So those personal stories are very powerful, and you'll find a number of your patients willing to do that with some encouragement from you when you've helped them through, especially some health challenges in your practice. So mobilizing your patients to make policy changes in your community and beyond is another way that patients can be engaged as champions of health. So let your patients work with you and let them work as a part of your team, and let them extend you and your influence in the community in which you live. Some resources for you. One is the Lewis W. Sullivan Institute. I mentioned they have a report on guiding principles for patient experience that might be helpful for you. And then the Ohio Patient-Centered Primary Care Collaborative on its website has information that talks about consumers and what patients can use as tools to become more engaged in their own health. So with that, thank you all for attending this part of the webinar, and I think I'll turn things back over to James Pat to deal with any questions that we might have.
Great. Ted, thank you so much for taking the time. Just a wealth of information. We really appreciate that. Again, we're going to open this up now to questions, and several of you have already chatted some questions, and we'll get through as many of these as we can. If you have additional questions, again, please go ahead and enter in your question on the chat box, directly to me, James Pat, and then again, we'll address as many of these as we can. So, Dr. Winslow, several questions here. First one is, Dr. Winslow, what you presented makes perfect sense, but how do we start acting in this new engaged model while most incentives and payments are still fee-for-service?
So that's a great question, because we're living in a fee-for-service world, and if you do all these things the way they're laid out, you'll probably go out of business. You may go broke. So what you have to do is what you can with your existing model. So the beauty is that when the national PCMH initial trial occurred, and that was back in mid-2000s, what Transformed found out going into practice was that, and by the way, there was no payment reform built into that, is payments could, practices could do a number of changes for them that would help them be able to do this type of care. First of all, make sure that all your staff are functioning at the top of their license. So if you have nurses in your practices and they're rooming patients and doing vital signs, you're not using them at the top of their ability. They could be doing your medication reconciliation. They could be clarifying and updating past medical history and other information in your charts and preparing all that for you so that you personally aren't going through all that effort, and then you can streamline your time with the patient by building on what your nursing staff already has accumulated as information. And then doing those handoffs to other members in your practice is certainly facilitated by having a record that everyone shares. So in some of our sites we have behavioral health, we have oral health, we have other services. Having all of them share a common record certainly facilitates that transfer of information back and forth versus having to try to fax or write notes or send emails or other things and transfer information. Again, slows down the process of doing timely transfers of information. One thing in private practices they focused on, and they found this in the TransferMed project, was many of them weren't billing at a level of service that they were providing. And by not billing at the level of service they were providing, they found there was missed revenue that could have been used to expand some of these other services in the practice. So they were underbilling, making only enough to cover the salaries of the people that were in the existing practice. And by billing appropriately, they were able to expand to add care coordinators in some of these practices, and some of them actually added community health worker types that they could afford now because they billed off of the level of service they were actually providing. I know in our FQHCs with prospective payment, that's not as applicable to your Medicaid and Medicare patients, but it does apply to your private insured patients. And so you want to be sure if you're doing extended visits, you are charging for extended care, thereby enhancing your revenue, which then allows you to expand some of these care services in your practice. Many of the practices that I've talked to that have instituted care coordinators have had to focus that care coordinator not on every patient in the practice, but instead on those with the highest level of illness. They have the most comorbid conditions. And by doing that, have been able to effectively really impact not only the quality of care they're delivering to those people with multiple illnesses, but also the cost of the care that's delivered to them. Now, many of those cost savings have been received by the insurance companies on the private market side, and we're now in discussions with them statewide about sharing some of those savings with us as we're exploring the opportunity to become an independent practice association, IPA, for those centers that are ready to move forward with participating in some of that shared savings. And as you know, we've worked very strongly with the state of Ohio on the State Innovation Model Grant, where they will be providing to PCMH practices per member per month care coordination payments that'll happen before you see those patients to help you with these care coordinator expenses, electronic expenses, information exchange expenses, and other things that you're incurring to do this model well. So hang in there for those of you who say, well, nobody's paying me for this, how am I going to do all this stuff? Because we do have payment reform coming in our state innovation model, which is right now being devised and perfected in Southwest Ohio in the Cincinnati, Dayton, Northern Kentucky region of the state. So thanks for the question. Do not wait for payment reform to start making change happen in your practice. Make sure you're billing for the level of service you're providing. Be sure all of your staff are working at the top of their license. Be sure you're talking to each other. You can start doing huddles now. You can start doing the other methods of exchanging information now and streamline your practices. You'll find there are many opportunities to streamline patient flow if you use that lean management process and engage all of your staff in trying to improve your efficiency.
Great. Great. Thanks, Ted. Another question is, it's good practice to refer patients to other practices like dentists, massage therapists, et cetera, but we rarely get information back from those referrals so we can make our care plan better. We cannot rely on our Medicaid or Medicare patients to tell us about those visits as well. There must be a better way to get this data than our patients. Do you have any recommendations with that?
Sure. So in practice, when I had a number of optometrists and ophthalmologists in my community that I could refer to, and I was having trouble achieving my retinal exams on my diabetic patients, I sent letters to all the ones I referred to, and I said, I will no longer be referring to you if you do not provide me information about my patient visit to you that relates to their retinal exams. Well, some didn't respond to that and some did. And the ones who responded and said, we will provide that for every visit that comes to our office, that's who I refer to. And the other ones I stopped referring to. So there's tremendous power in your referrals and value in your referrals. And I guarantee you the referral docs want your referrals, but they many times don't know how important this is to you, and they maybe don't have a mechanism for doing it automatically. What you want to do is give them that kind of feedback and say, I'm going to be limiting my referrals to people who give me feedback. But remember, that also means you have a responsibility. And your responsibility is to give them information when you refer your patients to them. You have to model this behavior. So I never sent my letter out to my consultants until I assured them that I would give them a note and that would explain why I'm doing this referral, what the patient's on as far as medications and their underlying illnesses, and what I expect during that visit with them, what I want out of the visit. Then I said to them, now I expect you to give me this feedback that I've asked for. I've given you the information I promised you. I need the information from you back to me. That did change behavior, and some practices go into contracts with their consultants, and in their contracts they actually have an agreement with them, and both of them sign it. And the primary care doc says, I will send you this information, and I expect back from you this information, and they have both of them sign it and have an agreement that clearly defines what the responsibilities or roles are. You remember in our slides we talked about people on the team have to have clearly defined roles. And really, you're going to have to educate your consultants. But the best way to start the conversation is by you doing the right thing in the first place, and that is showing them what a responsible referral looks like from a primary care clinician. And those who don't give you what you're looking for, I mean, if you're in a position where you can choose your consultants, choose the ones who give you the information back that you need to provide the best care for your patients.
Great, great. Thanks, Ted. Another question is around social determinants of health that you speak to. How can we track the social determinants of health and use in our clinical engagement?
So there are some products that are out there now for actually building this into your patient demographic information in your charts. And so programs, and one I'm familiar with is Civic Health. They build that into your patient intake information, and so that will build in employment and their housing circumstance, their education level, the other social determinants like environmental factors are built into that. And so that is available to you, but it's an add-on probably to your existing electronic record. There are many other tools, you know, inside and other organizations obviously are trying to see if they can't be more comprehensive in providing you with that base of information. Your local Department of Health has a lot of that information about the geopolitical boundaries in your region that you serve. So they will know, if you know the zip code of your patient, what the exposures are and social factors that you might want to be considering that relate to where they actually live, the street they're on, and the zip code that they find themselves in. So what I do on a global population basis is I encourage all of you to hug your local health commissioner and let them know you're interested in this and say, how can we better connect with the information you have on the people we serve in this geography that we're interested in. On the individual level, I encourage all of you to get more information. Remember, we used to just do age-sex registries. Then we ended up adding cultural and ethnic background information, and now we can add employment, and you can add education levels, and how do you prefer to learn, and other type parameters in your questioning of patients. As you start building that in, you'll get a rich database that you want to use when you're making decisions with your patients. Now, those of us who saw patients for 25 years, the same families, we kind of knew this stuff because over time you got to really understand where they're coming from, and you understood their families and the other social factors impacting them. But, you know, for your partners, that's not helpful when they're cross-covering for you, or for a consultant you send them to, that's not terribly helpful either, because that information is lodged in your mind and your memory. So we've got to get it out there where it's more useful to others in our databases. And the good news is many, many tools are coming forward that now will help you accumulate that information and be able to use that when you make decisions.
That's great. Thanks, Ted. I think we have time for one more question, and then again, both Dr. Wimslow's email is online as well as mine. If you have additional questions and would like to email those to either of us, we'll make sure we can try to get those addressed as well. But I guess the last question, Dr. Wimslow, is the FQHC Advanced Primary Care Practice demonstration ended last year. It helped many of us get PCMH certified. Do you know of any upcoming funding opportunities to help recertify or get first-time certification for PCMH?
Well, you know, our own effort, as you know, we're doing teaching health center development here with a primary care workforce initiative. Our $2.7 million that used to fund our care of the uninsured is now being directed towards teaching more in our health centers. That is only available to PCMH sites in our system as advanced primary care sites. So your eligibility is determined by your PCMH status for that. In the state of Ohio, as they're moving the state innovation model forward and going to new sites around the state, they're going to use a blended reimbursement model for those of you who are PCMHs, and that is they will not only pay a fee-for-service base rate, they will to that add a per member per month care coordination fee and then make you eligible for shared savings. Again, those will happen if you're a patient-centered medical home, and they won't happen if you are not. So those of you who went PCMH, continue to develop and further build that. That's always step one in your transformation process to operating as a coordinated medical neighborhood. But realize funding from all the insurers now is being realigned behind those care coordination principles. So if you don't do that, you won't be eligible for per member per month care coordination fees and shared savings in the future. So hang in there as the state innovation model moves forward. It's stated that, and the goal of the state government is that within 4 years, 80% of all people who live in Ohio will receive their care in a patient-centered medical home. So behind that is insurance companies, the governor's advisory council on healthcare payment reform, and a number of other activities that are moving us in that direction. So if you're already PCMH, you're in a good position. If you're not, please move forward. If you're already PCMH, keep advancing, if you would, to becoming a high-performance organization, an HPO, because that's that next step that you want to aspire to. And look that one up, high-performance organization. That's where really your next step should be going.
That's great, great. Dr. Wimslow, again, thank you so much for taking the time out of your day. Just a wealth of information. Also, again, we'd like to thank the sponsors, Ohio Association of Community Health Centers, Cardinal Health, and United Healthcare as well, for, again, helping to sponsor and promote this webinar series. Did want to announce that, again, this was scheduled to be a 5-part series. We are actually going to add a bonus webinar that will be held on Tuesday, August 18th. So go ahead and mark your calendars now. As part of that, if any of you have topics or specific questions that you'd like to address, please go ahead and email us that to us, and we're going to start gathering these topics and specific questions. Again, we'll address that as part of this value-based care panel on August 18th. Okay, and then our last scheduled webinar series is next Tuesday, August 11th, and this will be on value-based payment contracting. And Tracy Davidson from United Healthcare Community Health Plan of Ohio will be talking on this subject. So, again, thank you everyone for taking the time. I'm hoping everyone sees the value in these. Please send us questions or topics for the value-based care panel. As I mentioned, the presentation and the recording of this is available, so everyone should be receiving a link to that probably immediately following this presentation. If you have any additional questions, feel free to contact any of us, and I hope everyone enjoys the rest of their day. Thank you so much for participating.